We go to the next talk. We have utilization of whole kidney, Dr. Abushawar.
Good morning, everyone. Thank you, Dr. Suresh. Today, I'm going to talk about some high KDBI transplant kidney, and we'll see the outcome. So I'll start with the first one. We are going to talk about a 66-year-old female. Sorry. Okay. About a 66-year-old female with past history of high blood pressure for 16 years, ESRD due to high blood pressure on hemodialysis since 2017, hyperlipidemia, surgical history was like left knee replacement, social was retired, lives with husband, no smoking or tobacco, there is no living donor. Basically, before doing the transplant, we usually do like pre-transplant evaluation for the patient to see if she can or he can tolerate the transplant. She has a good exercise tolerance. Echo was good. Her body group was A, and she has like CBRA 99, which means that she has so many types of antibodies against so many types of kidneys. She had no previous transplant. There is no contraindication for transplantation. For the donor blood group was A, and also this patient, the KDBI was very high. It was 89. There was no warm ischemic time. Warm ischemic time basically means that the time passed from when the donor heart stops working until we remove the kidney and put it in the cold environment for transplantation. As this patient, he has brain death, we don't have warm ischemic time. The creatinine initial was 0.8 and the peak was 2.4 and terminal 1.9. Her post-transplant course, she had uncomplicated surgery. Basically, before doing the surgery, we give the patient like immunosuppressive medications to suppress their immunity as induction. And after the surgery, we start them on like usually 3 medications as a maintenance therapy to keep them like immunocompromised, so they decrease the risk of the rejection. After the surgery, this patient didn't have like any delayed graft function. Her kidney started working immediately and making urine. And after like follow-up after 2 years, the kidney was still working fine and she was making good urine. It's about the case number 1. Case 2, it's about a 58-year-old African-American male with ESRD on hemodialysis due to diabetes and she has diabetes for 20 years. She has also hypertension, gout, CVA, with weakness also. She has no surgical history. She doesn't have any living donor. Also for the pre-transplant evaluation, it was very good. He has a limited exercise tolerance. Echo was also good. Blood group was AB, and there was no antibody. There was no also contraindication for this patient. The donor blood group was A, KDPI was 80, still high. Warm ischemic time was 16 minutes. Creatinine initial 0.9, terminal 1.4, peak 1.4. Also, the post-transplant cause was uncomplicated, but this patient developed like delayed graft function when the kidney didn't work immediately after the transplant. That's why we need to support this patient by doing dialysis. So we started him on dialysis, but after like 2 weeks, his kidney started working again and we stopped dialysis. Basically, that when any patient has like the delayed graft function, we discharge them our approach on dialysis and we'll follow up in the transplant clinic. We shift them from the morning to night shift for dialysis. Before going to the center, they come to us so we can evaluate them if they need any dialysis or not. And usually when they get dialyzed, we keep them like 0.5 kilogram above them dry weight to keep them well hydrated and the kidney has good perfusion. It's about the cases. And also, I want to talk about a study that's talk about the impact of the delayed graft function and the long-term survival of the kidney after transplant. So basically, we know that the incidence of delayed graft function after the kidney transplantation has increased over time, as because we are right now utilizing more kidneys with high KDVI, donors with kidney injury and donation after cardiac death. DGF has increased resource utilization and concern for poor outcome, including rejection and worse graft survival. However, the data supporting poor outcome associated with DGF, including rejection and graft survival, remains inconclusive. Some studies suggest that this diseased graft survival, which may be related to a higher rate of rejection, haven't found any association. In this study, it's like we hypothesis that the duration of the delayed graft function, not that just the DGF itself associated with long-term survival. It's like single center retrospective study that contains the patient who received transplant from 2008 to 2020. We divide the patient to three categories. Patient who developed DGF less and needs this or less than 14 days, patient who needs this from 14 to 27 days, and patient who has DGF for more than 28 days. The primary outcome was to study the effect of the DGF on the graft survival. As we see here, we have like around patients who received transplant from 2008 to 2020 were around like 3,000 patients who were included like 14. From them, we have around 686 patients with DGF, and we have around like 749 patients with DGF less than 14, and around 2117 from 14 to 28, and more 52 from above 28. It's the baseline characters of the donor recipient. We will see the focus on the KDVI as we see from the patient who has like 900 patient with no DGF, patient who has KDVI more than 85 was 104, patient who has DGF less than 14 days out from 749, it was like 92 patients, and patient who has DGF from 15 to 28 out from 217, it was like 32, and above 28 patients who had, there was 52 patients, sorry, patients who had KDVI was 9. So the result here that basically patient comparing graft survival with DGF and there is no DGF, we say that the survival almost same, no difference between patient who has DGF and who didn't have GF after like 5 years of transplant. But when we divide comparing the result between the patient who has DGF, no DGF and the patient who has DGF like subgroups, we find that the patient after like around 7 years, the survival from the patient who didn't have DGF or DGF less than 14 days or from 14 to 20 days, it's much more than the patient who has DGF about more than 28 days. And by numbers here, we can say that the patient who has no DGF, like around 700 after 8 years, the kidney is still working in 200 patients. But in the patient who has DGF more than 28 days, out from 52 patients, we have just 5 patients who still working graft. So we can say that delayed graft function more than 28 days was associated with inferior graft survival. As conclusion, inferior graft survival was observed only in recipient of kidney transplant with DGF lasting beyond 28 days. DGF lasting less than 28 days have no impact on graft survival. Duration of a graft survival rather than the DGF itself is associated with the graft survival. Thank you.
Thank you, Dr. Abushawar.